If you are over 60 and taking Metoprolol, there is something happening inside your body right now that your prescription label will never explain. Not because your doctor is dishonest, not because the pharmacist forgot, but because the appointments are short, the warnings get rushed, and the details that protect you at home, the ones that matter on a Tuesday night when your heart feels strange, or on a morning when you can barely get out of bed, those details are the ones most patients never fully hear. I am Dr. Marcus Reed, and I want you to stay with me today because by the end of this video, you are going to understand 11 truths about Metoprolol that can protect your heart, your safety, and in some cases, your life. Not the textbook version, the real version. The version that matches what actually happens when you are living with this medication day after 60. And before I say anything else, let me be clear about what I mean when I say what your doctor won't tell you. I do not mean your doctor is hiding the truth. I mean most appointments run 12 to 15 minutes. The prescription gets written, the dose gets explained, and the part about what to watch for, what to avoid, what should never be combined, what should never be stopped suddenly, that part gets compressed into a sentence or skipped entirely. You get home, you open the bottle, and you are alone with a pill that is doing more inside your body than most people realize. Metoprolol is one of the most prescribed medications in the world. It is in tens of millions of pill organizers right now. But common does not mean simple. And over 60, the body around that pill is different. The kidneys filter differently. The liver processes differently. The nervous system responds differently. The margin between the right dose and a dangerous one gets narrower with every decade. That is not a reason to fear the medication. It is a reason to understand it completely. So let us start with truth number 11, because this one changes everything before the bottle is even opened. Metoprolol is not one medication. It is two different drugs wearing the same name. And if you are on the wrong form for your condition, the difference matters more than most patients are ever told. I want you to think about Raymond, 71 years old, a retired school principal who told me with full confidence that he had been taking Metoprolol for his blood pressure for 6 years. When I looked at his records, I found he had been switched between Metoprolol tartrate and Metoprolol succinate at 3 different points in those 6 years. Once after a hospital stay, once when his pharmacy changed suppliers, and once when a covering physician saw only the drug name and not the formulation. And Raymond had no idea. He thought it was the same pill with a slightly different look. Here is what every patient over 60 deserves to know. Metoprolol tartrate is the immediate release form. It works quickly, lasts 6 to 12 hours, and is typically taken twice a day. Metoprolol succinate is the extended release form, sold under the brand name Toprol XL by AstraZeneca. It releases slowly over 24 hours, taken once a day, and is the preferred form for heart failure and for stable long-term blood pressure management. These are not interchangeable in all situations. The peak levels differ, the timing differs, the clinical evidence differs. For someone with heart failure, the American Heart Association guidelines specifically support succinate, not tartrate. For someone who needs tight rhythm control after a heart attack, the immediate release form may be appropriate in early phases. If you have been on Metoprolol for years and you do not know which form you are taking, that is not a gap in your curiosity. That is a gap in your care. Look at the bottle. Find the full name. If it says succinate, it is Toprol XL. If it says tartrate, it is the short-acting version. And then ask your doctor one question. Is this the right form for my specific condition? That question alone could change your treatment. And that takes us directly to truth number 10, which is the one that surprises people the most. Metoprolol was probably not prescribed just because your blood pressure was high. And if you do not know the real reason it is in your daily routine, you are making every decision about it based on the wrong understanding. Edward was 68, a retired contractor who came in frustrated after reading an article online that said beta blockers were no longer the first choice treatment for ordinary high blood pressure. He had been on metoprolol for 4 years, and he looked at me like I owed him an explanation. He was not wrong that guidelines had evolved. He was wrong about what that meant for him personally. Edward had a history I had to remind him of. 2 years before starting metoprolol, he had experienced episodes of rapid heartbeat that were diagnosed as supraventricular tachycardia. His resting heart rate had been sitting at 92 beats per minute. He had mild angina with exertion. Metoprolol was not chosen for him because his blood pressure number was high. It was chosen because his heart was working too hard, too fast, under too much demand. This matters enormously because when patients think their medication is only for blood pressure, they make decisions based on that assumption. They check the number on their home blood pressure cuff, see it looks reasonable, and decide the medication must be working well enough to skip doses. Or they read an article and decide their doctor is behind the times. Or they get a prescription change for something else and stop the metoprolol without mentioning it because they figure they can handle blood pressure another way. Metoprolol manages at least 5 different clinical problems: high blood pressure, heart failure, chest pain from angina, recovery after a heart attack, and abnormal heart rhythms. One of those 5 may be your reason. One of them may be saving your life right now without a single dramatic symptom to announce it. If nobody has ever told you which job your metoprolol is doing, ask before the next refill. Say these words exactly. Why was metoprolol chosen for me specifically? The answer to that question changes everything about how you treat this medication. Metoprolol can make you feel 10 years older than you are. It can drain your energy, slow your motivation, cool your hands and feet, and flatten the mental sharpness you used to take for granted. And because this happens gradually, most people over 60 file it under aging and never connect it to the pill. Beverly was 73, a woman who had been sharp, active, and proud of her garden. 8 months after starting metoprolol at 50 milligrams daily, she came in saying she felt like she was living behind glass. Her words, behind glass. She was tired in the mornings, disengaged in the afternoons, and cold even in mild weather. She had stopped her evening walks because she felt unsteady and unmotivated. Her family thought she was depressed. She thought she was simply getting old. What she was experiencing has a clinical explanation. Beta blockers like metoprolol slow the heart rate and reduce the force of each beat, which is exactly what they are designed to do. But in doing so, they can also reduce cardiac output slightly, lower energy availability to the muscles, and suppress some of the adrenaline signals that normally give you drive and alertness. In some patients, particularly over 60, this translates into the kind of fatigue that feels constitutional, like it belongs to you now, like it is just who you are. And the cold hands and feet are not a coincidence. Metoprolol can reduce peripheral circulation as part of how it works. Beta blockers constrict the smaller blood vessels in the extremities. For someone in their 70s who already has some degree of reduced circulation, this can feel significant. None of this means metoprolol is wrong for you. For many people, especially after a heart attack or with heart failure, the slower engine is exactly the protection the heart needs. But patients deserve to know the trade-off. If you suddenly feel like you have aged dramatically since starting metoprolol, do not quietly accept it. Do not blame winter, retirement, or poor sleep for 6 months before mentioning it. Bring it up at the next appointment. There are dose adjustments, alternative beta blockers like carvedilol or bisoprolol, and sometimes combination strategies that preserve the cardiac benefit while reducing the fatigue burden. The hidden truth is not that metoprolol causes these symptoms in everyone. The hidden truth is that when it does cause them, almost nobody connects the symptom to the pill. If you have diabetes and you take metoprolol, there is a warning buried in the pharmacology of this drug that most patients are never given directly. Metoprolol can hide the most reliable warning sign your body produces when your blood sugar drops dangerously low. Franklin was 66. a retired bus driver managing both type 2 diabetes with insulin and a heart condition that required metoprolol after a cardiac event 2 years earlier. For most of his adult life, when his blood sugar dropped, he knew it immediately. His heart would pound, his chest would feel tight, his hands would tremble. Those symptoms were his alarm system. They were what told him to reach for glucose tablets before things got worse. After starting Metoprolol, those signals became quieter. The racing heartbeat that used to be his first warning barely registered. The pounding in his chest that told him to act was blunted. And one afternoon at home, he did not feel the usual urgency, did not respond in time, and his wife found him confused and barely responsive on the kitchen floor. What happened to Franklin has a pharmacological name: beta blocker masking of hypoglycemic symptoms. Metoprolol blocks the beta receptors that produce the adrenaline-driven warning signs of low blood sugar, especially the rapid heart rate and the chest pounding. The sweating may still occur because that is a cholinergic response, not a beta-adrenergic one. But in older adults whose sweating response is already reduced, even that signal can be unreliable. This is not a reason to stop metoprolol if your heart needs it. It is a reason to change how you monitor yourself. If you take insulin or sulfonylureas like glipizide or glimepiride alongside metoprolol, you need more frequent blood sugar checks, not fewer. You need a continuous glucose monitor if your doctor agrees it is appropriate. You need your household members to recognize the signs of hypoglycemia that do not depend on your own body's alarm system. And you need your blood sugar targets reviewed because in some patients, the acceptable floor level changes when warning symptoms are blunted. The hidden truth is that metoprolol and diabetes are not simply compatible. They require a specific management conversation that most patients are never offered. There are ordinary things in every medicine cabinet that can make metoprolol behave unpredictably. Not exotic drugs, not something a specialist prescribed. Things sold in every pharmacy, grocery store, and health food aisle in the country. And most patients over 60 are taking at least one of them without knowing what it is doing alongside their heart medication. Gloria was 70, meticulous about her health, proud of her daily routine. She took her metoprolol every morning at 8. She also took diphenhydramine, the active ingredient in Benadryl and Zizquil, every night to help her sleep. She had been doing this for 2 years and thought nothing of it because it was not a prescription, it was just a sleep aid from the drugstore shelf. What she did not know was that diphenhydramine is an anticholinergic drug. In older adults, anticholinergics can affect the heart's conduction system and interact with the rate-slowing effect of metoprolol in ways that are unpredictable. They can cause confusion, impaired balance, and in some individuals contribute to abnormal heart rhythms. The American Geriatric Society includes diphenhydramine on its Beers criteria list of medications potentially inappropriate for adults over 65. Combined with a beta blocker, the cardiovascular picture becomes more complicated. But diphenhydramine is just one example. Certain antidepressants, particularly the older tricyclic class like amitriptyline, can interact with metoprolol and elevate blood levels of the drug to unexpected heights, intensifying its effects. Some antibiotics, including ciprofloxacin available as Cipro from Bayer, inhibit the liver enzyme that processes metoprolol, which can cause the same drug accumulation. Antacids containing aluminum and magnesium, like Malox, can reduce how well metoprolol is absorbed if taken at the same time. And then there is a category that surprises patients the most: herbal supplements. St. John's wort, sold widely by brands like Nature's Sunshine and Natrol at Walmart and CVS, can increase the rate at which metoprolol is broken down, potentially reducing its effectiveness. Hawthorn extract, often marketed as a heart-supportive supplement and found at health food stores like Whole Foods and Natural Grocers, can enhance the blood pressure-lowering effect of metoprolol beyond what is safe in some patients. The hidden truth is not that you need to stop everything. The hidden truth is that no supplement, no over-the-counter sleep aid, no herbal capsule, no antacid is automatically safe just because it does not require a prescription. Every new thing that enters your bloodstream applies for a job in an ecosystem where metoprolol is already working. Before it gets hired, it should be checked. And the most dangerous days on metoprolol are often not the ones years into treatment. They are the first days after starting the drug, the days after a dose increase, and the days immediately following any period of inconsistency. And nobody warns you about those specific windows of risk. Harriet was 78, a sharp woman who prided herself on independence. Her doctor had increased her metoprolol from 25 milligrams to 50 milligrams after her heart rate was running higher than her cardiologist wanted. She took the first higher dose with dinner, went to bed, woke up at 2 in the morning to use the bathroom, stood from the bed, and found the floor coming up to meet her before she fully understood what was happening. She did not break a hip. She bruised her elbow and frightened her daughter who was staying in the guest room. But hip fractures in adults over 70 are among the leading causes of loss of independence, and a significant percentage of them begin exactly this way. Not with a dramatic accident, with a medication that worked exactly as designed in a body that needed time to adjust. When metoprolol lowers the heart rate and reduces blood pressure, the cardiovascular system needs time to recalibrate. After a dose increase, the brain, blood vessels, and nervous system are adapting to a new baseline. In older adults, that adaptation is slower. The mechanisms that normally compensate for a rapid drop in blood pressure when you stand, a process called orthostatic compensation, are already less reliable after 60 than they were at 40. Add a dose increase. Add nighttime when the autonomic nervous system is further suppressed. Add the disorientation of waking from deep sleep, and you have the conditions for a fall. The practical truth that every patient deserves to hear: after any dose change on metoprolol, treat the first 3 to 5 nights as a transition period. Sit on the edge of the bed for 30 seconds before standing. Turn on a light before you move. Consider a nightlight in the hallway and bathroom during this adjustment window. If you feel lightheaded or unsteady, sit back down and wait. Do not push through it and assume it means nothing. The hidden truth is that your doctor thinks about your 10-year cardiac risk. Nobody thinks about your next 3 nights. That information gap is where people get hurt. Metoprolol and alcohol are not a safe combination, and the warning most patients receive about this, if they receive any warning at all, is nowhere close to adequate. Thomas was 64, a social man who enjoyed 2 or 3 glasses of wine with dinner most evenings. He had been on metoprolol for 8 months. He did not drink heavily. He drank the way many people his age drink, as part of a relaxed evening routine that felt harmless and normal. Then one evening after dinner, he stood up from the table, felt the room tilt violently, and grabbed the back of his chair just in time. What Thomas experienced has a straightforward mechanism. Alcohol is a vasodilator. It relaxes blood vessels and lowers blood pressure independently. Metoprolol does the same through a different pathway. When both are active in the body simultaneously, the combined blood pressure lowering effect can become significant, particularly in older adults who already have reduced vascular resilience. The result can be a sudden, severe drop in blood pressure when standing, the kind that bypasses warning and goes directly to dizziness, stumbling, or collapse. Beyond the blood pressure interaction, alcohol affects heart rate and rhythm in ways that compete directly with what metoprolol is trying to do. Alcohol can trigger episodes of rapid or irregular heartbeat. In someone whose metoprolol is working to keep the heart rate controlled, this creates a push-pull dynamic that in some individuals produces palpitations, chest discomfort, or an unsettling sense that the heart is behaving erratically. This does not mean one glass of wine will send you to the emergency room. It means the combination deserves a specific conversation with your doctor that most patients never have. It means that the amount of alcohol that felt perfectly fine before metoprolol may need to be reassessed. And it means that standing quickly after drinking, even moderately, carries a fall risk that your body before metoprolol did not carry in the same way. The hidden truth is that social drinking feels so normal that patients never think to mention it, and doctors rarely ask. That silence is where injuries happen. Metoprolol can trigger or significantly worsen a breathing condition you may already have. And the patients who are most at risk are often the ones who would benefit most from having their breathing problems treated aggressively before they end up in an emergency room. Clarence was 71. A man who had smoked for 20 years before quitting at 50. He had mild COPD, which his pulmonologist had characterized as stable and manageable, with an albuterol inhaler used on an as-needed basis. After his cardiologist started him on metoprolol for heart failure, Clarence noticed within 2 weeks that he was reaching for his albuterol inhaler more frequently, then more frequently still. Then he was waking up at night with tightness in his chest. That was different from anything he had felt before. What was happening inside Clarence's airways is a known pharmacological effect. Metoprolol is a cardioselective beta blocker, meaning it is designed to primarily target the beta-1 receptors in the heart rather than the beta-2 receptors in the lungs. Cardioselective is not the same as lung safe. At higher doses, or in patients whose airways are already reactive, metoprolol can still act on those beta-2 receptors and cause bronchoconstriction, which means tightening of the airway tubes. In someone with asthma, this risk is considered significant enough that metoprolol is often avoided entirely and replaced with a different medication. In someone with COPD, the decision is more nuanced because heart failure itself can cause breathing problems, and treating the heart condition may ultimately help lung function. But the key word there is nuanced. It requires a specific discussion between the cardiologist and the pulmonologist, a discussion that many patients are not told needs to happen and so never ask for. If you have asthma, COPD, or any reactive airway condition and you are taking metoprolol, you need both your heart and lung doctors in the same conversation about your care. If your breathing has worsened since starting metoprolol, do not simply increase your rescue inhaler use without raising the flag. Bring it up specifically. Say these words. Could my metoprolol be affecting my breathing? Because in some patients, it absolutely can. There is a specific time of day when metoprolol works best and a specific way to take it that significantly affects how well it protects you. Most patients are never told either detail. Margaret was 69, organized and careful about her health. She took her metoprolol tartrate every evening with dinner because that was when she remembered it and the routine felt comfortable. Her blood pressure readings in the morning were consistently higher than her doctor wanted. Her cardiologist kept adjusting the dose upward. What nobody identified was that the timing was the problem, not the dose. For metoprolol tartrate, the immediate release form, the peak effect occurs 1 to 2 hours after taking it. The medication then loses potency over the next 6 to 12 hours. For someone taking it with dinner at 7 in the evening, the peak protection is at 9 at night, when they are sitting quietly watching television, and the medication is substantially weakened by 6 the next morning, exactly when the cardiovascular system is naturally most stressed. The hours between 6 and noon represent the period when the body's cortisol surge, rising blood pressure, increased heart rate, and heightened platelet stickiness converge. This is when most heart attacks and strokes occur. The protection your medication offers needs to be at its strongest precisely in this window. For the immediate release form, that means morning dosing or twice daily dosing if that is what your prescription specifies. For Toprol XL, the extended release succinate form, the timing is more flexible because it releases evenly over 24 hours. But food still matters. Metoprolol is better absorbed when taken with food. Not a full meal necessarily, but not on a completely empty stomach either. Taking it with a small amount of food reduces the variability in absorption and gives you more predictable blood levels throughout the day. There is also the matter of not crushing or chewing extended release tablets. Toprol XL tablets are designed with a release mechanism that is destroyed if the tablet is broken. Some patients with difficulty swallowing crush their medications as a matter of habit or a caregiver does it for them without understanding the consequence. Crushing metoprolol succinate releases the entire dose at once, converting a 24-hour medication into an immediate release surge with potential for sudden heart rate drop and dizziness. The hidden truth is that how you take metoprolol and when you take it are not minor details. They are clinical variables that affect how well the medication protects you every single day. Your heart rate on metoprolol can drop too low, and the warning signs of a heart rate that has gone too far in the wrong direction are subtle enough that most patients dismiss them for months before anything gets checked. Arthur was 72, a former high school football coach who came in complaining that he felt unusually heavy when he walked, like his legs were asking for something his lungs were not providing. He also mentioned, almost as an afterthought, that he had been checking his pulse recently, and it seemed slow. When I put my fingers on his wrist in clinic, his pulse was 44 beats per minute. His prescribed target range had been 55 to 60. A resting heart rate below 50 on metoprolol is a signal that needs attention. It may mean the dose is too high. It may mean the medication has accumulated due to a kidney function change, which is common as kidneys gradually lose efficiency after 60. It may mean another medication added to his regimen was interacting in a way that amplified metoprolol's effect beyond what was intended. The symptoms of an overly slow heart rate are not dramatic. They rarely announce themselves as a cardiac emergency. They feel like fatigue that seems disproportionate to your activity level. They feel like breathlessness on an incline that was not there 6 months ago. They feel like the kind of dizziness that makes you grab a railing, not the kind that knocks you over. In an older adult whose baseline energy and cardiovascular reserve are already lower, these symptoms blend into what aging looks and feels like. And so they go unreported for months. Here is what you need to know. If you are taking metoprolol, you should know your resting heart rate the same way you know your blood pressure. A basic pulse oximeter, available at any pharmacy including CVS and Walgreens for around $20 to $30, will give you both. The Zacurate Pro Series 500 DL is one of the most consistently accurate models at that price point. Take a reading in the morning before you get up, before coffee, before activity. If your pulse is consistently below 55, write it down and bring it to your next appointment. If it drops below 50, call. The hidden truth is that the heart rate monitoring conversation almost never happens at the appointment where metoprolol is prescribed. And in an older body where the margin of safety is already narrower, that omission can cost months of unnecessary suffering. Stopping metoprolol suddenly is one of the most dangerous things a patient over 60 can do. And the most frightening part of this truth is how easily it happens, for reasons that feel completely reasonable in the moment. Robert was 75, a retired accountant who prided himself on discipline and clear thinking. He had been on metoprolol for 3 years for a combination of heart failure and a prior arrhythmia. One week, feeling unusually tired and frustrated with his medication schedule, he decided to take a few days off. He thought, I feel fine. My heart feels fine. A short break will help me feel like myself again. He did not call, he did not taper, he did not look it up. On the second morning off the medication, he woke with his heart hammering in his chest. By midday, he had chest tightness and shortness of breath significant enough that his daughter drove him to the emergency room. His blood pressure had surged 40 points above his normal range. His heart rate was racing. He was terrified, and he did not understand why. What Robert experienced is called beta blocker withdrawal rebound. When the body has been receiving metoprolol over a long period, it adapts. It upregulates its beta receptors, meaning it grows more of them as a way of compensating for the medication's suppressing effect. When the medication is removed suddenly, those excess receptors become active all at once, flooded with circulating adrenaline that now has far more docking points than it did before treatment started.